My name is Catherine Pettis. I'm the International Association for Hospice and Palliative Care Senior Advocacy and Partnerships Director. We are very happy to be co-hosting this webinar with the International Narcotics Control Board, the World Health Organization, the UN Office of Drugs and Crime, and we have two board members, Dr. Felicia Knoll and Dr. Lucas Broadbrook from IHPC joining us today. This webinar falls under the advocacy program, Objective 3, which is to increase collaboration with key stakeholders to improve the balanced approach to and rational use of essential palliative care medications for legitimate medical needs. So just to give you a quick introduction to the International Association for Hospice and Palliative Care, we're a global nonprofit organization with members all over the world. You can see in all the red dots on our website, this is an interactive map. If you click on the dots, you can see the members in each country. We're a non-state actor in official relations with the World Health Organization and an NGO in special consultative status with the UN Economic and Social Council, which gives us the status to advocate for access to palliative care and controlled medicines in all the different UN organizations. And one quick reason, because it's very complicated, and you'll hear some of this today, why we need to have this webinar on improving availability, is that access to essential palliative care medicines such as morphine is very problematic in more than 86% of the world, partly because access, availability, and affordability are entangled with the International Drug Control Conventions, which are listed in the picture on the right. There are 3 of them, all of which were developed and established before palliative care developed, and that creates a lot of problems for access. We've made a lot of progress. We've been advocating for a while. So this is part of the progress we're making in advocating and educating the international community about availability. The INCB and IHPC this time last year signed a memorandum of understanding. This is Professor Jalal Toufiq, who was the president then, and he said that the INCB and IHPC share common objectives with regard to the provision of guidance and support to governments and the international community on issues related to the availability of controlled substances for medical and scientific purposes. So this is part of our collaboration with INCB as well as the World Health Organization. These are your panelists and your moderator. Your moderator will be Dr. Afsan Badilia, who's a professor at the at Purdue University, and a longtime collaborator with IHPC. Her bio will be in the chat, along with all the other bios that of the panelists who are speaking. They're full bios, and we just don't want to spend a lot of time introducing everyone. So Afsan will be introducing everyone, and you can read the bios in the chat. So I'm going to stop sharing now and hand you over to Afsan, and you have the floor, Dr. Badilia.
Thank you so much, Captain Dr. Pettis. Hello, everyone. And we'll introduce, before I turn it over to a close colleague, mentor, and friend, Dr. Felicia Knoll, who is a member of the IHPC board, chair of the Lancet Commission on Palliative Care and Pain Relief, Vice Chancellor at the University of California, Los Angeles. Among many of their accomplishments, Felicia will present her research on how governments and palliative care advocates can accurately calculate the need for essential medicines that comprise the estimates which will be upcoming and described by Professor Asran Gornchai. This is work on measuring the burden of serious health-related suffering in particular, and tools and platform to have open access to that data. Over to you, Dr. Knoll. Thank you so much for switching order.
Thank you, Dr. Badilia. And in effect, we have worked together for a very long time, including on the work that you're going to see today. I just want to give a very, very special thanks to the INCB as well as to the IAHPC. But just to highlight, and what you'll see in the presentation, how important it is that we've been able to have this incredible partnership with the INCB in openness to sharing data, to looking at the quality of the data, to reviewing and to strengthening the data. And, a particular thanks to Stefano Bertarame, who's been working with us as an incredible colleague for many years. Not all agencies and individuals are as open to being the kind of collaborators that you have been and continue to be. So our thanks. And a very early morning here in Los Angeles. So from UCLA, from the Chancellor's residence, welcome to you all. And let me just go ahead now and try to share screen. You will tell me if it is working as it should. Of course, it would be nice if it went in presentation mode, wouldn't it? There.
Seeing it great. Well, Felicia.
Should be okay?
Yes.
Nothing blocked and
Thank
all
you.
working fine. All right. We're going to update you on availability of data from our Lancet Commission and moving forward. I'm grateful to all who participated from the hub, including, of course, Drs. Rajbush and Bedelia, and many others, some of whom are listening today, and a number of institutions that participate in this work, including, of course, IHPC, the Tec de Monterrey, Tomatelo Pecho, and many others from around the world. The estimates that you're going to see are based on the global burden of disease produced by the Institute for Health Metrics and Evaluation. These are the 2021 data. We're in the process of updating using the recently released GBD 2023. As I mentioned, what you're going to see pulls from the Lancet Commission on Global Access to Palliative Care and Pain Relief that was produced and published in the Lancet in 2017. The link is there. It's freely downloadable. This was work with the late and very dear Dr. Paul Farmer and many others, including Eric Krakauer. We had 33 commissioners, 61 co-authors, and we represented 25 countries here. We wanted to make sure that we could move from the work that was published and produced in 2017 and continue to push that forward. And this webinar is, of course, part of that. And we move forward to what we've called the Hub, which focuses on global access to palliative care and pain relief and contributes to health policy, research, advocacy, training, data generation, and the strengthening of palliative care systems worldwide. It is based at UCLA. We're very grateful for the support from the David Geffen School of Medicine. The Hub, however, was established in 2021, originally supported by the University of Miami. We have a diverse and global network of researchers, and we fundamentally seek to produce evidence-based global, regional, and national estimates, which you're going to see in a minute, both of serious health-related suffering and of distributed opioid morphine equivalents. We are very committed to capacity building. Many and all who are listening are welcome to join, and we've to date trained a number of graduate students and early career researchers. So we are very grateful for you and to your participation from around the world. We'll go very quickly through four things. What is serious health-related suffering? Then DOME, access to opioid medicines. We're going to merge the two to see how you can look at need versus accessibility, comparing DOME to serious health-related suffering, and a tiny bit on work in progress. So the how-to of what we call SHS, serious health-related suffering. You select the health conditions that generate a need for palliative care, and then for both adults and children, each health subcondition has a corresponding multiplier for both decedents, those who die of that disease in that year, and non-decedents, those who are at risk but do not pass in that year. And that represents the proportion of people requiring palliative care. And we get those multipliers through expert group and literature review. And the more we can move forward these expert groups, the stronger our work will be. For decedents, the multipliers are applied to all deaths from that cause. And for non-decedents, it's somewhat more complicated because we have to apply a PC multiplier to health condition-specific prevalence data that we typically draw, or majority are drawn from the global burden of disease. The how-to is published in detail in the Journal of Pain and Symptom Management that came out in August of 2024 and available for you to peruse and use. I said we picked the conditions. We have 21 health conditions now that are included, and the data on the number of people with SHS, both decedents and non-decedents, are available from 1990 to 2021. We are currently in the process of making that annual. Right now, it's over 10-year periods. In addition, but this is somewhat older data that was developed in 2015 for the 2017 publication of the Lancet Commission, we have days with SHS, both from 11 physical symptoms and 4 psychological symptoms. But again, you've got updated numbers of people linked to somewhat older data on the number of days of suffering. But what you can do with these data then is to measure suffering by symptom. So you can take pain in this case and link it to the health conditions that are associated with that pain, that symptom, or you can take a health condition and link it to the symptoms that we have in our database. The database right now that you'll be able to look at and see online on SHS has the following framework. You can look by country, income region, or geographic region for any of this. It starts with the overall numbers on serious-related suffering, SHS. Then you can go decedents or non-decedents, by sex, female or male, by age group, 4 age groups at this point, and each of those 21 health conditions. So that's the structure or framework. How have we applied this? For example, we have a new publication coming out led by Julia Downing and others, including Dr. Bedelia, which look at SHS by age, and that publication looks at 0 to 19 years, so children. You can analyze by region or by country. An example is the paper that came out in Lancet Regional Health Americas in 2023 on the Chilean case. And you can look by condition, by health condition. The example here is the in-process Lancet Respiratory Medicine Commission, the weight of air, currently led by many, but very much by Dr. Billy Rosa, who is very active and participates in our hub. What did the data get you? So in terms of the number of people, you can look at, these are the data for 2021, at least 74 million people worldwide. You can demonstrate that the vast majority are in low and middle income countries. You can look at children, more than 10 million children, 98% in lower middle income countries. You can look by number of deaths, 27 million, and compare that to total number of deaths in a year in the world. And you can look at non-decedent need, in this case, 46 million individuals. And you can look by condition. The lead conditions you'll come up with are cancer, HIV/AIDS, cerebrovascular disease, dementia, and endocrine metabolic blood and immune disorders. I won't go into detail, but I did want to show you, for those who are interested, that you can produce much more detailed analysis over time. In this case, it's 1990 to 2021, decedents, but by communicable, non-communicable, injury-related, and HIV as conditions. So you can do all of this, and this also breaks the data down by low income, lower middle, upper middle, high income, and all. So you can do quite complex analysis with the data that are available. How do you access these data? They're available in Harvard's Dataverse. There is the link there. It's linked and working with the IAHPC. We're very thrilled to have the IAHPC as our partners in this, and you should be able to get a free download out of this from the Harvard Dataverse. We would very much appreciate if you do download the data, that you contact us and tell us how you're using it and how it worked, and of course, any issues you might have. So that's SHS, but we want to link SHS, which is need, to what is available. What we did in our commission was to identify an essential package, and at the core of that package is access to opioid medicines for pain. And we developed an indicator called distributed opioid in morphine equivalent, or DOME, working very closely with the INCB. We use the INCB data collected from country reports, and we pull the following medicines: morphine, pethidine, codeine, oxycodone, hydromorphone, and fentanyl, and we link that back to morphine equivalent with appropriate adjustments and weights. So this gives us an idea of what opioids are available in the best case scenario, all of which for palliative care, the way that we do the analysis. So the methodology, again, we use the INCB data. We adjust the potency to morphine. Therefore, we are able to quantify unmet need, and as you'll see in a minute, compare DOME to SHS. The details of how we do this are also published in the Journal of Pain and Symptom Management. We are very grateful to this journal, which is lead edited in many ways by, again, Dr. Billy Rosa, for giving us this unusual space to be able to publish all of the methodology of the how we do this data and where to be able to get it. What can you do with these data then? You can look by medicine over time, adjusting by a low, lower middle, upper middle, high income, or country specific, as you'll see in a minute. And you can see major changes over time that are also very deeply linked to equity issues. You can map these. This is 1990 to 2022. In the case of the DOME data, we have a few extra years, and we keep building from the INCB, and you can see how things have changed by medicine in this case in the world over a 30-year period. But what we want to get to is this, which was sort of the signature figure of our Lancet Commission, where we link need to availability, measured with this one particular indicator, which is a tracer of access to palliative care in the world, and say, what is going wrong? This map has been used quite a bit. The bottom line is it shows that the 50% poorest in our world have less than 1% of the DOME. And the DOME, in this case, would be thought of as entirely applied to palliative care, which, of course, is only a part of the need in and of itself. So it only gets to be worse, more inequitable, more issues of access if we actually look at all the different need in addition to palliative care with what you're seeing here. You can, with our data, the way they're structured now, not only look at a map in one point of time, which was that 2015 map that we published in the Lancet. Now you can see how things have changed by region over time in terms of ability or inability to meet the need that we're measuring through SHS. We were not going into detail on what this is telling you because the idea is to give you an idea of the data and what you can do with the data. But the bottom line is we see marginal improvements, but still huge inequities and enormous unmet need, particularly in low and middle income countries. As I had mentioned, you can also look at these data now by country, thanks to having the INCB data available. We've chosen 3 examples here: Colombia, South Africa, and Thailand. While we have data for almost every country in the world, not all of that data allows you to analyze countries across the entire continuum from 1990 to 2022 in this case. But you can actually consider country-specific analysis, and it does, in each and every case that we have looked at, give you very interesting information on changes in the reliance on different medications and comparing that, controlling for how need has changed, particularly with epidemiological transition measured in terms of serious health-related suffering. What are we doing now? We are working towards SHS 3.0 in the hub, which requires very detailed condition-specific work. And that is why, in part, we're doing so much work with Billy Rosa and his Lancet Commission on respiratory illness. We are thinking about packages beyond the essential and minimum and what can and should be provided in resource poor settings, differentiating for children. And we are attempting to move forward something that we had begun to discuss in the Lancet Commission, which is what is the real value to patients and families of universal access to palliative care and pain relief. And that we have begun to think about as suffering adjusted life years as a first cut. Each of these steps involves much research, funding that is typically unavailable. And so I just want to say how grateful I am to so many who have dedicated their time and institutions who have supported us, including, of course, the IAHPC and INCB. Thank you very much.
Thank you so much, Dr. Knoll, for sharing the work on estimation of the burden of serious health-related suffering, how to calculate it, how to access the data to, so others can utilize it in their settings. And to add a note that we will have a presentation and linked with that, one of the last points around the packages and differentiating for adults and children and development of expanded packages with Dr. Radbush. But before we do that, I want to return back to Professor Asan Korchai, who is representing the INCB. And I just want to check if we have that presentation ready. Professor Asan Korchai, are you ready?
Yes.
You have the floor. If I don't know if the slides have been shared. I don't see them.
No, not yet.
Okay.
Are you going to share the slide?
No, I'm not able to. I thought that you would be.
Oh, you
Also,
want me to share the slides?
Yes, Catherine, were you able to fix
I'm
the
going to
video?
share the slides, fine. And then you will give the narrative. I will do that.
Unfortunately, I was restricted in downloading it when I tried.
Okay, I'm going to try again. Get presenter mode.
first, let's start with the basics. The INCB, or International Narcotics Control Board, is an independent body established by the 1961 Single Convention for Narcotic Drugs. We have dual mandates. First, to ensure there are enough controlled substances for medical and scientific purposes, and second, to prevent those substances from being diverted into illicit trade. These mandates are worked through the estimates system, which I am going to talk about in details. The legal cornerstone for this control is the Single Convention on Narcotic Drugs. This treaty mandates that governments must limit the use of controlled drugs exclusively for medical and scientific purposes. The convention controls 141 narcotic drugs, including common palliative care medicines, for example, opium derivatives such as morphine, synthetic opioids like fentanyl and methadone. And here is how the estimate system works for narcotic drugs. Governments submit annual estimates of their needs for narcotic drugs for the coming year. Crucially, these estimates set the legal ceiling for the country's import and manufacture. Once the INCB confirms these estimates, a country may legally manufacture or import those drugs. So it is a critical mechanism. Each year, the national authority has to submit Form B, which is the annual estimates of the requirement of the narcotic drugs for the coming year. During the year, the national authority can submit the supplementary Form B if they want to increase or reduce the annual estimates. And the country also has to submit Form A, which is the quarterly statistics, and Form C, which is the annual statistics of the production, manufacture, consumption, stocks, and seizures of narcotic drugs. So how the country calculate the estimates? This is based on the statistics for consumption, production, imports, and exports from the previous year. In addition, they need to take into account the healthcare system's service capacity and the nature of the morbidities common in the country. The INCB also published a guide on estimating the requirements for substances under the international control. Once INCB confirms the estimates, they publish them on their website and update the estimates monthly. Now, let's look at another system, which is the assessment system for the psychotropic drugs. Unlike the estimate system, the assessment for psychotropic drugs is a voluntary system for countries to report their psychotropic drugs needs for medical and scientific purposes. such as buprenorphine, pentazocine, and benzodiazepines. Similar to the estimate system, the national authority has to determine the quantity of psychotropic substances needed and submit the data to INCB using Form BP. Although it is voluntary, almost all countries submit regular updates of their assessments. We also have a supplementary to Form BP for the government to modify the assessment of a specific substance without a full submission. Once established, the assessment remains in effect indefinitely until the country submits a new assessment. Here is the INCB website page where the assessment data of psychotropic drugs are published and updated regularly. To help the member states ensure access to controlled substances for medical and scientific purposes, INCB has developed the INCB e-learning. It has two main elements. One is technical training on controlled drugs, and the other is the availability workshop, where we train national authorities on the techniques and forms for use in the estimates and assessment systems. The IAHPC has been a fantastic partner in this work. Your representatives consistently participate in our workshops, promoting our work as an instrument to heighten awareness of the importance of adequate access. So we thank to the International Association for Hospice and Palliative Care for its work. Let's look at some key achievements of INCB. In 2024 alone, the INCB reviewed and confirmed over 3,800 estimates, which cover more than 1,500 tons of narcotic drugs used in pain management and other therapies. This is a huge volume, and it shows the system is working. However, it needs to work better for everyone. At the end, I would like to talk a little bit on the challenges of the system. You may wonder why this process matters so much to the palliative care community. The estimate system is a mechanism that either ensures or denies access to essential pain medicines. If a country's estimate for pain medication is too low, our governments submit estimates that do not reflect the true medical needs of their population. It creates a legal bottleneck. Imports are legally blocked if they exceed the country's official estimate. The direct result is stock shortages and untreated patient pain. Look at this map. It shows another crucial challenge: the geographical disparity of access to narcotic pain relief. The data is stark. 81% of the world's population, mostly in low and middle income countries, consumes only 15% of the world's total morphine used for pain management. The vast majority of consumption is concentrated in North America and Western Europe. This creates a massive access deficit. Well, to conclude, I hope I have convinced you that the INCB estimates and assessment systems are not merely a technicality. For our patients, estimates are access. For the palliative care community, the system is the mechanism that either ensures or denies access to essential pain medicines. Thank you. I welcome your questions and comments.
Thank you so much, Professor Asankornchai. Really appreciate you taking the time to share the important pathway through which governments and the INCB estimate system can ensure access to essential medicines for palliative care. I want to turn now Dr. Lucas Radbruch to talk a bit about the recent work on development of or building or from the work of the Lancet Commission on Global Access to Palliative Care and Pain Relief around essential packages, and to develop expanded packages that are differentiated for adults and children. This was part of a grant through the Medical Research Council, a multi-country study in partnership anchored at the University of Edinburgh, with a work stream that was led by IAHPC, that led to the development of the work that Dr. Radbruch will present. Dr. Radbruch is the chair of the IAHPC board. He's also chair of palliative medicine at the University of Bonn and director of the Department of Palliative Medicine at the University Hospital Bonn. Dr. Radbruch, over to you.
Thank you very much. Just going to share my slides. Hope you can see that. And I'd like to start with just saying that opioids such as morphine are among the oldest medicines known to mankind. And so it's really curious that we still have problems with administering that. As you heard before, there's some elements that need to be fulfilled in order to have pain relief to all those who need it. One of that is that you have to have policies on the ground, for example, regulating import. Then INCB has discussed that. You have to have good estimates how much opioids you will need. Felicia Nowell has talked about that. But you also have to have knowledge, education of healthcare professionals to know how to use that. So when we discussed the problems with access to pain relief with people in low and middle income countries who are not that familiar with these medicines, quite often we got feedback saying that, this is really dangerous stuff and we don't know how to use it, and so we better stay away from it. From the IAHPC, led by Liliana de Lima, who I think is not available today, we were happy that we were invited by WHO to submit an application for palliative care and pain relief medications for the essential medicines list of the WHO. And that was acknowledged in 2013. There was a new section implemented on analgesics and other medicines for symptom relief. You can see the listing of the medications there. Actually, most of those had already been included in the ML, but they now are put together in the second chapter of the essential medicines list, and that had been updated repeatedly. So by now, there's other opioids that have been added, like fentanyl and methadone. Also, oxycodone and hydromorphone are named as alternative opioids, and other medications for symptom relief. And you already heard about the similar process run by the Lancet Commission on Palliative Medicine, which, with a different methodology, resulted in quite similar set of essential medicines. The blue ones are the ones that were included additionally to the WHO essential package. Some of these very important, like petroleum jelly, which you need, for example, for wound care. Others may have been discussed for a long time, but that is the list of essential medicines from the Lancet report. And the Lancet report, I think, was really great because it not only discussed the medicines, but also the equipment and the staff requirements of such an essential package. And these are the essential equipment and essential staff packages from the Lancet report. You may say that that's quite a lot, for example, for the staff requirements, including physical therapists, for example, psychiatrists. But mind you, this is not on a primary care level. This is just that these staff people are available for consultation within expert teams that are reachable by primary caregivers. And actually, the Lancet report also calculated the cost of such an essential package and found that not only the medicine, but taking it all completely with staff and equipment, it's not that expensive, calculated as a percentage of gross domestic product. health expenditure or percentage of public health expenditures. As you heard, the recent project was on revising the essential packages and drafting an essential package for children and drafting expanded packages for children and adults. We had an elaborate consensus methodology with a steering group. We had a pre-test done and a Spanish translation done because quite a lot of the people who were participating were from Latin America. We did then 2 Delphi rounds with nearly 90 experts on adult care and about 50 experts on pediatric care. 2 rounds, as I said. Then we worked on that, tried to revise the packages, and then we had a second panel with experts, most of them from low and middle income countries, a bit smaller, but still 26 adult experts and 18 pediatric experts. And then we had the final go around with the steering committee again. So you can see it's a multi-step process with a lot of consensus procedures and consolidation phases in between. Now, we were quite happy that the essential package for adults was, in a sense, pretty much unchanged. There were only 2 substances like diphenhydramine and ondansetron that were excluded in this new essential package, saying that other antiemetic medications like metoclopramide and haloperidol would be sufficient for the essential package. And we didn't have no additional medications for the essential package. And if you look at the pediatric package, then it is rather similar to the adult one, though I have to say that the dosages naturally and the application routes often are different. So there is a good reason for having a separate pediatric package, but fortunately enough, the medications as such are pretty similar. It was more difficult to discuss the expanded packages, so I'm not going into details here. You can see this is a screenshot from the publication that is out there in the Journal of Pain and Symptom Management with the lead author, Tanya Pastrana. And you can see that it is pretty expansive, pretty comprehensive. So there are several antidepressants, antiemetics, gastric protection. Also with the equipment, there were additional things added like syringe drivers, for example. And for the human resources, we did have a few positions that were withdrawn from the essential package, like the oncologist was not deemed necessary for the essential package, but was included in the expanded package. We did not yet do any cost calculations on this, and I'm pretty sure that for low and middle income countries, this probably will be taxing to provide these expanded packages. But for centers for tertiary care, for example, I think it would be appropriate that they do not have only expert oncology expertise, but also palliative care expertise, and that they probably, these centers of excellence in each country, even in low and middle income country, probably should be available, should have availability of all these expanded medications. When we discussed all this, we thought that maybe we also need to give the healthcare professionals on the ground, on the primary care level, some more information how to use this. So from the IAHPC, at the same time, we did a consensus process on a manual for the use of essential medicines, which was finalized only recently. Similar consensus process with 19 experts in the steering group, a Delphi process using more than 60 experts from 50 countries. We took great care. We had a stratified approach that we had really enough people from low and middle income countries that participated and, with the specific considerations of their resource poor settings. We consolidated information, had another panel with 23 experts, again, a fair share from low and middle income countries, and then produced from that the final manual. This is the way it looks. So this is really very basic, and I have to say that in a lot of places we discussed, for example, starting doses, titrating steps, and maximum dosage, lockout times for repeated dosages. And there's a lot where I, as a specialist working in Germany in a high resource setting, would have gone with much higher dosages. But we repeatedly reminded ourselves this is really for the primary care level in unexperienced, low resource settings, and we have to be rather careful with this. So these are really safe recommendations how to use medications. And the example I've taken here is the use of morphine, which is quite often mentioned only for pain relief, but is also a really important medication for the relief of breathlessness. And the last step, finalized only last week, is that there's also an online app with this manual where you can, on the IAHPC website, you see the link here, where you can use the menu to select the symptom that you want to treat. You get the medications that are included in the essential medicines lists and packages, and you can see on very concise information on application route, dosage, frequency, and maximum dose. So that's the support I think primary caregivers need in order to be able to use these essential medicines. There's also one thing that we collected from these projects and packages, and that is that quite often medications still are not available. Morphine is available in a lot of countries, but not in all. But additional opioids such as hydromorphone or methadone are not available in 1/3 or more of the participants' countries in these consensus processes. And you can see that also other medications quite often are lacking. And that is really a bit scary to see that not only the opioids, but also the other medications that are really essential for the treatment of symptom relief in severely ill and dying patients are quite often not accessible, not available. With that, happy to turn back and waiting for the Q&A later on.
Thank you so much, Dr. Radrish. You have provided, I think, the next step in the logic, and you provided an important summary at the onset of, the sequence of information, data, the collaborative work, the global collective action that is necessary to promote balanced policies. So from the INCB estimate system to the SHS burden to then the packages, these are the steps necessary to improve palliative care for patients. Let me now turn to, it's my great pleasure to turn to Mr. Deus Mubangizi, currently the Director of Medicines and Health Products Policies and Standards Department of the World Health Organization in Geneva. Mr. Mubangizi recently oversaw the department and publication of the new WHO guideline on balanced national controlled medicines policies to ensure medical access and safety, an essential tool for governments and advocates to improve availability, accessibility, and affordability of controlled medicines in countries where people who need them have limited or no access. Balanced policies are essential to ensure adequate availability while reducing preventable public health harms from misuse. So it is my great pleasure, Mr. Mubangizi, please turning it over to you for your presentation. Thank you for being here with us today.
Thank you so much, and it's a pleasure to have an opportunity to share with you the recently published guideline on balanced national policies on controlled medicines and to ensure access and safety. So I would like to thank IAHPC and INCB for inviting me to give this presentation. And let me see whether you see my screen.
Yes, it is visible now. Thank you.
Good. Okay. So as you indicated, I'll share with you on the recently published guideline on balanced national policies on controlled medicines to ensure medical access and safety. And this is a guideline that replaces the older one that was withdrawn, I think, way back in 2011, and is aimed at providing guidance to member states in developing and implementing national policies on controlled medicines to ensure accessibility, availability, and affordability for medical and scientific uses. and of course, indeed, to minimize risk to harm arising from non-medical use. Of course, this guideline addresses policies for all age groups and a number of populations, but also affected conditions in which the use of controlled medicines is deemed medically appropriate according to evidence-based clinical practices. The guideline aimed at answering two questions. One was on what national policies and implementation strategies are effective in improving appropriate access to controlled medicines. And then the other question was what national policies and implementation strategies are effective to ensure safe use of controlled medicines, including limiting non-medical use. So those are the two questions that we attempted to answer in these questions. Of course, the populations that were intended to be covered by this is a wide range, starting from conditions of pain or various pain, using anesthesia pre and post surgical care, in palliative care, which is, this association focuses on management of mental health disorders, substance use disorders, neurological disorders, and also, of course, in the context of humanitarian or health emergencies, but also in other settings, exploring emergent medical conditions on controlled substances. So, as I said, all ages substances were intended to be covered right up from neonates to the elderly. It took actually very long to address because there are a lot of controversies around this guideline, and of course also the process was disrupted by our diversion to focus on a response to COVID. But we picked it up again, especially in 2024, and build momentum to finalize it in 2025, where it was launched at the sidelines of the World Health Assembly this year. 7 domains were identified from the development and implementation of national policies to the pricing and financing of controlled medicines, and then selection, but also quantification, procurement and supply, medicines regulation and control, prescribing, dispensing and administration, and of course education and knowledge and attitudes. And particularly these 4 to 7 were the focus of the systematic review. In terms of the controlled substance, of course, that was intended to cover all medicines with authorized medical or scientific purposes, not those that don't have authorized medical and scientific purposes. And of course, that ranged from opioids, but also up to amphetamine type stimulants. What this guideline did not cover and does not cover is clinical, it addresses policy rather than clinical practice. It does not cover clinical practice and therefore does not provide advice on clinical use of controlled medicines. That should be known upfront. When there were a number of guiding principles, and I think 7 or 8 of them, but one principle was that all people, without any discrimination, are entitled to enjoyment of the highest attainable standard of health. And therefore, they should have access irrespective of their status. They should have access if they truly need these controlled medicines. The second principle was the recognition that controlled medicines indeed are crucial and for managing a number of conditions, and access to these controlled medicines is a component of the rights to both health and life. The third principle was that these national policies should be in place to ensure balance between enabling safe access to safe and appropriate use, ensuring that access for medical and scientific use as needed, but of course, to ensure that there is also appropriate measures for avoiding harmful consequences to individuals and societies. So that balance is another principle that is embedded in this guideline. The other principle is to ensure that these policies, once developed, they should be tailored to the needs and requirements of the social context and resources of the population. Of course, recognizing the individual's rights to the attainment of the highest standard of health. So you need to recognize the individual rights, but also taking the social and resources context of each country. The fifth principle also was to ensure that member states should ensure that patients and their families and their caregivers know their rights for self-determination, non-discrimination, and access and appropriate health services and confidentiality. That principle is important. And of course, to make sure that all governments in doing so should invite all stakeholders to be able to participate in the formulation of these health policies. So it should be an inclusive process. Now, looking at the number of recommendations, as you know, we use the grade principle, and which had a number of recommendations, but in some cases, it was only good practice statements that were included and recommended. In the area of quantification of controlled medicines, there was a strong recommendation for governments to ensure that reporting of current consumption and potential need for controlled medicines for medical and scientific purposes, including ongoing adjusted essays where necessary, are accurate, timely, and actively monitored. Systems need to be in place to ensure quantification, and this should be based on need that estimated from the best available epidemiology data, including morbidity and mortality data, consumption data, and clinical guidelines, service capacity, and other data information. I was glad to hear the presentations before us actually really highlighting this point in the presentation. In terms of a number of good practice statements on the need to monitor availability and affordability of controlled medicines, and on the need to develop and implement and monitor procurement policy, and also on the need to develop and implement and monitor good procurement policy to identify and continually assess and evaluate resources and achieve the right prices for these medicines. In terms of supply chain, and there was also a strong recommendation that government should use simple but appropriate technology and tools to improve the traceability, efficiency, and integrity of inventory management for controlled medicines, but also to prevent waste and stockouts. And they should also implement protocols for prevention of diversion, and also reduce administrative burden for frontline staff handling controlled medicines. There were also good practice statements on the issue of supply chain and distribution plans to ensure geographical coverage. Often this is left to market forces, but indeed, as we said, the right for everyone everywhere to access, indeed, to make sure to have supply systems that ensure geographical coverage, but also prevent wastage and shortages. There was also a good practice statement on local and regional production hubs and supply chains that are supported by adequate technologies, infrastructure, finance, and human resources. On the area of local production of controlled medicines, the statement was really not to say there must be local production, but to ensure that there is a system to analyze information to see what are the potential health, financial, and social benefits, and as well as the risks of undertaking production of quality assured controlled medicines locally. And if that information supports so, then such a policy should be pursued. In terms of safety, medicine safety, again, here there were three good practice statements. One, to ensure that controlled medicines are available in formulations that are acceptable, affordable, and accessible to those who need them, but also to ensure that the packaging that is used, because these have a potential for abuse, the packaging prevents accidental use by children and vulnerable adults. And also a good practice to ensure that the adoption of tamper-resistant formulation and packaging to weigh the potential safety benefits against the high cost, because sometimes these have been adopted, but of course then they work against accessibility and affordability. So there should be some information and consideration on the pros and cons of all this. In terms of possession and use of controlled medicine, again, there was a good practice statement that requests governments to collaborate with health authorities and care providers so that to review laws and regulations regarding the possession and use of controlled medicines. We know that in some cases, these have been prohibitive, and their implementation overzealous to the extent that they have created phobia on the right to access these products when they are needed. So the need to review these, and I've said context appropriate to make sure that those who need them to access them legitimately for clinical purposes can access them. Another practice area was for regulatory agencies and healthcare professionals and society to ensure permission to possess or handle controlled medicine is extended to all health professionals whose practice entails treatment of patients with a clinical need of controlled medicines. In one way or another, this is a good practice statement, sometimes to encourage task shifting to ensure that the professionals who are available to provide treatment and care are enabled to do so, of course, safely and within the laws of the country. And of course, the training and professional competencies. And then, of course, another one was to ensure that the patients have adequate legal protection relating to the possession of prescribed controlled medicines in clinical need. In terms of scheduling, again, governments were advised to ensure that changes to the scheduling of controlled medicines are based on robust scientific evidence, because we see a lot about activism and also so of aspects informing scheduling, but in this respect, it should be based on robust scientific evidence relevant to the context of use to achieve balance between access, but also public health, prevention of public health harm. A practice statement also about scheduling should include input of health authorities and associations of health professionals, so that all stakeholders and families have an input when reviewing drug schedules, so that there's optimization of health outcomes and priority in balancing and access to clinical need and preventing harm. Another area of good practice is governments and relevant authorities to ensure medicine schedules do not impede access to controlled medicine for use in ethically approved clinical research. And of course, in terms of regulatory procedures for import and export, of course, and again, it's good that we have INCB here that supports and helps countries in this respect, that governments and relevant authorities should review their requirements and procedures governing trade and controlled medicine to ensure that they are appropriate and do not obstruct the control of medicines necessary to treat people in clinical need and competency to minimize diversion. And of course, there was also a recommendation to encourage universal use of electronic authorization and reporting in implementing trade regulations and controlled medicine, and also authorities to ensure controlled medicines can be exported or imported rapidly for you, especially during humanitarian conditions. You remember during COVID, there was a challenge on some patients in different parts in accessing their controlled medicines. In dispensing and prescribing, again, good practice was governments to ensure that they develop and revise independent experts according to the scientific process, but also optimize access to controlled medicines that are safe, and of course to ensure non-discriminatory and address the needs of specific vulnerable populations. A strong recommendation was for governments to develop, implement policies to ensure that prescription dispensing and administration of opioids agonist treatment are available for people with opioid dependence in settings which there is clinical need and should ensure continued access throughout transition of care. And a number of practice statements that I will actually not read for the sake of time, but of course about prevalence of non-medical of certain controlled medicines with associated harm. Also, another one on ensuring that regulation guidance on prescription and dispensing controlled medicine should be formulated to optimize safe use, and of course on ensuring that regulations also without undue barriers allowing them to work for full scope of their practice. And that's like including tasks shifting where necessary and appropriate. Of course, when these are available, also statements on their robust follow-up in terms of pharmacovigilance systems to allow monitoring of prescriptions for controlled medicines with specific attention to the protection of patients' privacy, but also to optimize access to safe use and of controlled medicines. And another one to ensure that monitoring prescription control medicine should not be used to expose caregivers and patients or prescribed to unwarranted scrutiny in the delivery and receipt of clinically indicated healthcare practices. Now, for industrial relations, the good practice was to ensure that regulations to ban misleading and unethical marketing of controlled medicines to patients, healthcare providers, and other stakeholders, but also to ensure international organizations and professional associations to implement robust, transparent, and to prevent and manage conflicts of interest in the training, education, and promotion of education of health professionals. And also for governments to implement policies to address undue influence, including preventing and managing conflicts of interest for regulators, and other government. Last but by no means the least is the domain on education and knowledge and attitudes. There was a strong recommendation that governments and academic institutions and other responsible bodies should promote and a comprehensive training in adequate access and safe use of controlled medicine. It's better to start this in schools, because even we've seen stigma among practitioners, especially when it comes to prescribing even palliative care medicines. And strong recommendations also to ensure that through appropriate authorities and institutions, the delivery of balanced and accurate information about controlled medicines to patients, families, and caregivers is in place. So this is a summary of the 7 domains and the recommendation and good practice. You and ourselves have now a responsibility to work with member states to make sure that these recommendations are put into place and they can facilitate, so that when we talk about universal access, it includes people who need access to controlled medicines. Thank you so much.
Thank you so much, Mr. Mubungizi. I think this was such a comprehensive presentation on the WHO guideline on balanced natural control medicine policies. I really appreciate the highlighting of the core principles, the right for every individual to be able to attain the highest level of health, the need for robust monitoring and evaluation systems, the tracing to avoid illicit use, but also avoid stockouts, and acknowledging also what you've noted about building awareness. But appreciating in particular the good practice statements. I want to highlight these, which are noted throughout the document. I know, by the way, there are some questions emerging, and I want to note to the audience, if you have questions, please add them to the chat. There's also a Q&A section. If we do not get to them given time, and if we don't get to them live, we will answer them online or over email. But thank you again, Dr. Mubungizi, for your presentation. Last but not least, we want to turn to our final panelist, Dr. Brendan Macer, who is the founding member of the Young Doctors Network, anchored at the UN Office of Drugs and Crime in Vienna, an initiative that aligns with the UNODC's program to increase availability of and access to controlled medicines for medical and scientific purposes while preventing diversion and non-medical use. The network's objectives include, among other things, advocacy, education, research, and data sharing, bridging health ministries and drug regulatory bodies. But I'm sure Dr. Macer will share more with you on that. Dr. Macer is a resident physician in general pediatrics at the University of Toronto in the Hospital for Sick Children or Sick Kids, and a PhD candidate through the University of Toronto Clinician Investigator Program. Dr. Macer, over to you. Thank you so much.
Thanks so much, Dr. Bedelia. Can I just confirm that you can see my slides okay and hear me okay?
Yes, perfect on both. Thank you so much, Dr. Macer.
Great. Thanks so much. Dear colleagues, fellow panelists, and distinguished attendees, thank you for the kind introduction, and thank you very much for this opportunity to present to you today, especially to the IAHPC, INCB, and WHO for hosting this webinar. I'm going to present on the topic of collaborative networks as a policy tool for achieving controlled medicines access and safety. And we'll give an overview of some work being done by the UNODC Young Doctors Network and briefly introduce the GPEC Global Opioid Working Collaborative, which is another collaborative network related to controlled medicines. Just to start, I have no conflicts of interest to declare, and I receive salary and grant support from those organizations listed. I also want to just start with a quick disclaimer before I begin to note that the views expressed herein are my own and do not necessarily reflect the views of the organizations with which I'm affiliated, nor do they necessarily reflect the views of the UNODC, the United Nations, or its member states. And while I'll be sharing about the objectives and activities of the UNODC Young Doctors Network, I will not be speaking today on behalf of the full YDN membership, nor on behalf of the UNODC program within which the YDN is hosted. Just a brief overview of the objectives for my presentation. By the end, I hope that you'll be able to recognize that controlled medicines access and safety are interrelated and quote unquote wicked problems, to appreciate the value of interdisciplinary collaborative networks for advancing advocacy and policy learning related to balanced controlled medicines policies, and to become familiar with two such collaborative networks, the UNODC YDN and the GPEC GLOW Collaborative, including both their scope and their priorities. Owing to the tremendous advocacy by IAHPC, INCB, WHO, and other global leaders and experts, including that of the other panelists here, many recognize that we're facing parallel global crises related to controlled medicines, and particularly for opioid medicines. First, there's the non-medical use of opioids and opioid-related harms, which remain prevalent and are growing in many contexts, most notably in North America, but also in some LMIC regions. Second, there's the inaccessibility of essential opioid medicines for pain relief and palliative care, which we've heard a lot about today so far, and this contributes to a tremendous burden of inadequately treated serious health-related suffering. But despite coordinated efforts to improve access and to reduce opioid-related harms, these problems persist. And one reason for that is that these issues can be characterized as so-called wicked problems, a concept that originated within the public policy literature. And like other wicked problems, the intersecting opioid crises result from endemic and complex systems with multiple interrelated components that interact in complicated, poorly understood, and unpredictable ways. Further, the responsibility for addressing these issues is spread across multiple sectors, organizations, and health system levels. The decision-making context for controlled medicines and for drug policy more broadly is complex and is characterized by conflicting and contesting objectives and by value-laden decision-making. This leads to low consensus regarding how the problems are defined and regarding the potential solutions. The figure that I've included on this slide is from a book by Alex Stevens called Drug Policy Constellations, which explores how network characteristics, distributions of power, and moral beliefs interact to produce outcomes related to drug policy. And the figure shows a network map of drug policy actors specific to the UK, but also relevant to the international context. And it's organized by actors' policy preferences and values. It demonstrates how actors tend to cluster around particular policy positions according to their underlying moral views about controlled substance use. And the reason I include this here is just to highlight the contested decision-making context for controlled medicines and to show how relevant policy actors tend to segregate according to their existing perspectives. Owing to the complexity of these problems, policy solutions to achieve a balance between access and safety have remained elusive. Policy change often requires learning and a change in perspective regarding problems and their potential solutions. But unfortunately, wicked problems make for so-called wicked learning environments, where there's inaccurate feedback and lesson drawing regarding interventions, ambiguous causal relationships, and conflicting objectives. However, one potential solution for overcoming some of these challenges in policy learning is the fostering of collaborative networks that cross traditional disciplinary, sectoral, and professional boundaries. Collaborative networks with diverse perspectives can help overcome some of the challenges of wicked problems by contributing to clarification of competing understandings, sharing and integration of diverse knowledge, and the generation of new knowledge and shared understandings. Networks can also help promote innovation and learning and contribute to what's called deep analogical reasoning and far knowledge transfer, where policy actors draw lessons from structurally similar challenges and solutions in other seemingly disparate policy areas. Such networks can also help overcome cognitive biases, including overconfidence in an actor's or group's beliefs and understanding, and foster new perspectives, contributing what's been called the outside view by Daniel Kahneman, or quote-unquote Fox thinking, as coined by Tetlock and Gardner in their book, Super Forecasters. In addition to these more ideational and learning benefits, collaborative networks can also contribute to progress in more material ways, such as by bridging competing coalitions on a policy issue, by supporting the pooling and sharing of limited resources among network members, by efficient coordination of activities and economies of scale, by enabling the adaptation and scale-up of effective solutions, and by opening up additional venues for advocacy, negotiation, and policymaking. So with these potential benefits of collaborative networks in mind, I'd like to use my remaining time to share with you about two such networks that have been recently developed for supporting efforts to improve access and safety of controlled medicines. The first of which is the UNODC Young Doctors Network, which was launched in 2024, or YDN for short, which is hosted by the UNODC program on access to controlled substances for medical and scientific purposes while preventing diversion and non-medical use. The YDN provides an informal platform for physician representatives from UNODC member states to collaborate on research, advocacy, and capacity building initiatives. To date, we have approximately 60 members from diverse disciplinary backgrounds with representation from all major global regions. The aim of the YDN is to build bridges among health professionals, drug control systems, and regulatory bodies through action across three pillars. The first is through improving access to and rational use of controlled medicines. Second, by preventing, detecting, and responding to diversion. And third, by preventing and treating non-medical use and misuse. Regarding our activities to date, we held our first in-person meeting earlier this year at the 68th meeting of the Commission on Narcotic Drugs, where we had the privilege of being able to deliver a plenary intervention to member states. In our statement, we outlined 5 priority areas for the network, which include building capacity through undergraduate and postgraduate medical training, promoting research to identify access barriers, uncover diversion methods, and design and implement solutions, to meaningfully engage communities by involving them in priority setting, implementation, and evaluation, by collaborating with and supporting health professionals to ensure the rational use of controlled medicines, and by reviewing and optimizing national and subnational policies related to controlled medicines. Since CND 68, the network has been engaged in multiple activities related to our objectives, and we're working to formalize our organizational structure and operations to support further productivity. Some examples of other activities to date include the development of a regional chapter for Africa, which participated in a technical consultation in October regarding access and availability of controlled medicines in Africa. We've hosted 2 webinars in conjunction with the International Day Against Drug Abuse and the World Hospice and Palliative Care Day. And our members have also been engaged in several other activities within specific topic areas, including diversion and children's access to controlled medicines. Moving on in just the few minutes remaining, I also want to mention very briefly about another collaborative network that colleagues and I have developed through the Global Institute of Psychosocial Palliative and End-of-Life Care, or GPAC for short, at the University of Toronto, which we've called the Global Opioid Working Collaborative, or GLOW for short. GLOW is an international collaborative of experts and leaders from multiple disciplinary backgrounds that aims to explore and develop solutions to address the complex and intersecting issues surrounding both opioid access and opioid safety. While I don't have time, unfortunately, to discuss in more detail, I've included here just a high-level overview of our leadership and membership to date, but I'd be happy to connect with anyone at a later time who's interested to be able to share more about this initiative and our forthcoming priorities. So in closing, I'd just like to leave everyone with 2 main takeaway points, which are that interdisciplinary collaboration is critical for achieving balanced controlled medicines policies, and coordinated research and knowledge translation are needed across policy, systems, and practice levels to promote effective policy learning and to overcome the challenges of wicked problems. And I want to end by acknowledging the tremendous efforts of Dr. Elizabeth Sands and Ms. Chiwigi at the UN ODC Program on Access to Controlled Medicines, which hosts and oversees the Young Doctors Network. It was Dr. Sands' vision and advocacy that has led to the development of the YDN and its continued progress. And I also want to thank Dr. Jenny Lau, my co-chair with the GPEC GLOW Collaborative, and our GPEC director, Dr. Gary Rodan, as well as the organizations who provided salary support for my time and my own PhD supervisors. I'm happy to share these references with anyone who's interested, and just in closing, want to share my contact information, and I'd be happy to connect with anyone after today. Many thanks for your time and your attention and for this wonderful opportunity. Thanks so much.
Thank you immensely, Dr. Macer, and highlighting the value of networked action. I want to also take this opportunity to thank all of our panelists for their invaluable presentations, to the audience for being patient with us in terms of the technical difficulties, but also gratitude that we are in a space such as this where we can convene from around the world together and have an opportunity to share knowledge and evidence. We don't have an extensive amount of time, so I'm going to ask one question, trying to merge some of the questions that have come up. There has been some note around issues related to waste and corruption, in addition to misuse and stockout of drugs, based on experience working in LMICs on one of the audience members, and then also a recognition and acknowledgement. Many of these barriers that are presented actually increase dramatically in conflict settings and humanitarian emergencies. And so I want to turn to the panel, and particularly starting with Dr. Mwangizi, in terms of the WHO guideline, which I think seeks to address some of these points. In particular, how is this guideline being shared with member states? Because this forum right here is sharing, and IHPC is doing an effort to share with civil society members, but of course, ministries of health and regulators need to know about this balanced policy to address some of the issues noted in the questions. Let's start with you, Dr. Mubangisi.
Yeah, thank you so much indeed. It's a good question that this guideline should not remain on the shelf. And we actually working out a program, and I must also be upfront here, thanks to the support of the Belgian government, to where we will be running seminars for different countries, but also webinars for different countries, but also with an opportunity to engage not only the Minister of Health, but also the legal framework within the country, because in some cases it requires to update their laws. So yes, we hope to run a number of webinars starting with 2026, not this year, starting with 2026. And we are in the process of finalizing the program. And I think I should say here, I look forward to the collaboration of a number of stakeholders, including those around this webinar, to be able to do that. Because, as you know, we have undergone restructuring, and we don't also have a lot of human resources in order to do that. But also the presentations that we had here give a lot of practical perspectives that may demonstrate how to operationalize some of these good practices or recommendations. So yes, come to 2026, we'll start engaging the member states on how to take forward this guideline. Thanks.
This is very good to hear, Dr. Mubangisi, and I wish we had a lot more time to do a full Q&A. I'm realizing that we are now just seconds away from the scheduled end of this webinar, and so let me take this opportunity to thank again immensely all of our panelists for their insightful presentations, for sharing the knowledge and evidence that is currently available to address this very solvable problem of the inequities in access to essential medicines, and to ensure access to palliative care services to address the growing burden of serious health-related suffering. Thank you to the audience for sharing with us across different time zones for your questions. We will follow up if there's anything pending on that. And so let me, Catherine, I don't know if you wanted to add anything else, but
just great thanks to you, Afsan, for your wonderful moderation, and to the panelists for their presentations. And the recording will be shared on the IHPC YouTube channel. So that will be available. Thank you.
Thanks, everyone. Have a wonderful rest of your day or evening, wherever you are. And we hope to convene again soon and continue the discourse. Take care.
Thanks to all.
Thank you.